So lung cancer is if you look at the Globacon data, if you look at the epidemiology of lung cancer right now, lung cancer would rank as the number one cancer as far as incidence and mortality is concerned, especially in men. The majority of lung cancer is due to cigarette smoking and the other variants of smoking. But then there is also a good chunk of lung cancers we see now in non-smokers, youngsters, both women and men who are never smokers. So there is a changing epidemiology to that extent. Breast, head and neck, cervix still constitute the majority of the cancers we see, but lung is around 5.5 to 6% of the total incidence, and the commonest as far as men are concerned with regard to incidence and mortality. So the challenges, if you ask me, are manifold. Considering that this is a preventable cancer in a subset of people who smoke, the first challenge would be educating people and preventing them from smoking, or developing it as a habit in youngsters who would then continuously smoke for a prolonged period of time, thereby exposing them to the risk of developing lung cancer. So that would be challenge number one, which is educating about the harmful effects of tobacco, which not only causes lung cancer, but a host of other diseases, which include non-communicable diseases like COPD, emphysema, heart diseases, and also different types of cancer apart from lung cancer. So education and prevention is one key. The second thing is which with regard to a diagnosis. So the problem we face more often than not in the cities, though most of the cities are well equipped, but in the rural areas maybe, is a interventional radiology backup. So lung is one specialty where you would need probably a bronchoscopy for a biopsy, you would need a CT guided biopsy, you would need mediastinoscopy for staging. So most of the cities are very well equipped. All the centers have excellent state of art facilities, but not so in the peripheries. So this would be a challenge. The third challenge would be processing of the samples and the treatment of lung cancer. The paradigm has shifted from histology based to molecular based. So the challenge would be having adequate tissue for all your molecular analysis, for your next generation sequencing. Cost is definitely going to be a challenge in resource limited settings, and supportive care and survivorship. So our lung cancer patients are living longer now. Gone are the days when your metastatic lung cancer patients were surviving for 6 months or 9 months. Now, average driver mutation lung cancer patients survive anywhere between 4 to 6 years. So, with longer follow up, with longer lifespan, you have longer follow ups. They have to be more compliant with their follow ups. You have newer sites of disease, rarer sites of disease where you pick up, which require newer modalities, out of the box thinking, and obviously an expenditure for the patient and the family. So these are all the challenges if you look at from a holistic point of view, right from prevention to diagnosis to investigation and treatment and survivorship. There are a lot of initiatives. For example, the anti-tobacco lobby is pretty strong. The packets of cigarettes are the very, very clear advertisements regarding the harmful effects of tobacco. Tobacco cannot be sold in the vicinity of schools, educational institutions, etc. So there are periodic ads with the government. So the taxes are very high on tobacco companies. But at the end of the day, it's a habit forming exercise. It depends on the individual. And with more and more people getting educated, more and more people having access, and with the changing in lifestyle, I think the education part is not going to be a one-time approach. It has to be a continuous variable, continuous approach where people across the board over a period of time get to know that tobacco in all its forms is harmful, not only for lung cancer, for all other kinds of diseases. And it's better to stay away from it. And yes, the government is doing its bit. To be really honest with you, for a person who's practicing in India now, I should tell you that we have no dearth of any of the anti-cancer molecules which we have to use for lung cancer. India is blessed in a way that most anti-cancer drugs are available, number one. Number two, the beauty is now for some of the common drugs which we use in lung cancer, like pemetrexed, erlotinib, geftinib, you have generics available which have substantially reduced the costs, which is accessible to the common man too. Erlotinib for a month's course would be possibly available for 1500 rupees, which is hardly $20 a month, which is unimaginable. And this is thanks to the generics, thanks to the multiple generics available, the huge competition amongst the pharma players. So access to drugs is not a problem. Immunotherapy is available. You have all the PD-1, PD-L1 antagonists available. You have all the MABs available. You have the VEGF inhibitor, bevacizumab, which has been there for a very long time, Pemetrexed and docetaxel. So access to drugs has never been an issue. And we also have the original molecules and the generics. So if you look at the evolution of lung cancer, in the last 15 years, we have seen the evolution of lung cancer. 15 years back, it used to be plain paclitaxel carboplatin, and then pemetrexed came in for adenocarcinomas. And then we have seen the EGFR and ALK, and now we have a ROS1, MET, RET, HER2 amplifications and all that. So increasingly, cancer is becoming biomarker driven. Increasingly, cancer has become NGS driven. And now, run-of-the-mill EGFR, ALK, ROS, PDL-N1 is done for most patients who come to a medical oncologist. So access to biomarkers is not an issue. And uh, so it is available in all hospitals. It is available with most labs. It can be outsourced. So liquid biopsy is also available for those patients where the tissue is insufficient. Though I would usually prefer tissue biopsy like most others. So access to biomarkers is not at all difficult, available in hospitals, available in private centers, and can be done free of cost too for most of the biomarkers, which include EGFR, ALK, ROS, PDL1, which are the 4 main or 5 main biomarkers which we need in the clinic. And for the poorest of the poor who are financially vulnerable, we do it free for some or most of our patients through some part of a patient access or a support program. Neither is cost a constraint for us now to order biomarker testing. That's what I was alluding to. It's not just that we don't have the technology or we don't have the resources, that is very much available. Cost is also not a constraint. It is not a foundation one kind of a test which costs maybe $3,000, $4,000. No. Many patients can get it free of cost in our clinic through some patient access program. So cost is also not a constraint if it has to come, if we have to do the biomarker testing. As I just said, increasingly, all of us in the clinic, the first thing which we do now in a metastatic setting is to check for most of our driver mutations. We commonly in the clinic check for ALK, EGFR, ALK, ROS, and PDL1. And then if they are negative and there is a still strong suspicion that he's a never smoker, young adenocarcinoma, then we would probably start looking at the further sequencing for RET, HER2, MET, etc., or for the rarer mutations, RAF, RAS, etc. So very rarely, sometimes when the patient is extremely sick and there is a delay in diagnosis and the patient comes to us, there are days we have started empirical erlotinib because in the lymphangitis carcinomatosis picture, once I remember, biopsy wasn't feasible. The patient was on non-invasive ventilation, could have landed up on a ventilator at any point in time. We sent a liquid biopsy sample, but we couldn't wait because the patient was sick. We just put them on empirical erlotinib and remarkable difference. And it is almost 1 year today, the patient is still doing fine. So these are some of the stories. There are a number of such stories which most of us would have. Patients on EGFR drugs doing well for 3 years, patient for 4 years, ALK positive doing well for more than 4 to 6 years. So testing for these biomarkers is key, especially in young, never smokers, men or women who have an adenocarcinoma histology. So the guidelines would be similar to what we follow worldwide. EGFR frontline would be either osimertinib or erlotinib. In India, you don't have a generic osimertinib yet, so it is prohibitively expensive. So I would rather, if cost is a constraint, I would start on erlotinib. And as I told you, erlotinib is hardly $15, $20 a month. and a year and a half later, if they progress, and if we are able to do a T790M and then positive, then we can probably think of osimertinib sequencing in those patients who can't afford. ALK inhibitors, all the ALK inhibitors are available, crizotinib, ceritinib, alectinib, lorlatinib, everything is available in India. And pretty much cost decides which you're going to. Crizotinib is available at patient access program. The below poverty line patients get it completely free. So that is one advantage. Alectinib is expensive, but in somebody who has brain mets, that would be my first choice if cost is not an issue. With regard to ceritinib, earlier it used to be 5 tablets a day, but then there's a paper where you can reduce the pill burden if you take 3 tablets with food. So that's what we do. So it reduces the pill burden, and it also reduces the toxicity, which is diarrhea, and most importantly, financial savings to the patient. So this comes to ALK, ROS, more or less similar. And with regard to PDL1, immunotherapy. Immunotherapy is standard, is first line as anywhere in the world for those who have more than 50% or 1 to 50% score. Available, again, coming down to cost, it is available at a much cheaper price than the West. And with the PAP program, it should range anywhere between $1,500 to $2,500 a month, but that's still very, very expensive to most patients. So my first aim would be to look for EGFR ALK ROS one. And if there are financial issues and if immunotherapy is not possible and if there are other driver mutation negative, then I would rather go for pemetrexed carboplatin, which serves them really, really well, followed by pemetrexed maintenance. Yeah, so what we discussed right now is purely from the metastatic lung cancer purview, where we speak about driver mutation positive, driver mutation negative, and immunotherapies. If I have to go back just a bit into looking at the adjuvant part, pemetrexed carboplatin or vinorelbine cisplatin as used in standard practice. And for those people who undergo chemoradiation and who have a response, durvalumab is very much available, and we do use durvalumab. Again, considering that durvalumab is there are no generics available and price is slightly on the higher side. For those patients whom I can't give durvalumab, 4 cycles of paclitaxel carboplatin as an adjuvant post chemoradiation is an option or as an alternative. COVID has been a very big game changer. So all of us would agree that in the initial days of Jan 2020, none of us knew how COVID is going to span out and how we have to take care of our patients. So there were lockdowns, patients weren't able to access treatment. The follow-up patients, we're not that much worried because they've completed treatment, we can do a video consultation, etc. But for those patients who are on active treatment, that was a cause of concern, because if a cure was a goal, and even those patients where palliation, good palliation was a goal, with things like where patients were having a very good response to chemotherapy and we had to abruptly stop it due to the lockdown or due to fear of contracting COVID, that created a lot of a problem. That was number one. Number two was the use of immunotherapy during COVID. So, as you know, that immunotherapy has a risk of pneumonitis of 5%, and the number doubles up to 7 to 10% if you're using a combination immunotherapy. So, immunotherapy during COVID times, with COVID itself leading to COVID pneumonitis, that was a cause of a concern. And I remember one of the very early patients whom we saw during the very early days when RT-PCR SAM testing was also not very freely available. It was only limited to the academic institutions. That was when patients coming with breathlessness, who are already having a background lung cancer, who are on immunotherapy, CT chest showing pneumonitis changes, you're unsure whether it is COVID, you're unsure whether it is immunotherapy pneumonitis, and that was creating a lot of a problem at that time. But now a lot of water has flown under the bridge in the last 2.5 years. We have learned to live with COVID, its multiple variants, and cancer treatment hasn't stopped. And thanks to the vaccines, we have a lot of data from the West, and we have some of our own data which we are going to present in a month or so, which shows that cancer patients, despite being on treatment, be it chemo or immuno, are producing substantial amount of antibodies to the vaccine. So that's a blessing for our patients that they take the vaccine and they take treatment and they're living during COVID. When it comes to follow up, that's fine. Video consultations are okay. And now, hopefully, the third wave or the fourth wave in India, whatever we call that, that settles down, then I think things will turn back to normal. Cancer patients have been, as you know, cancer patients have been excluded of from most of the trials, especially from most of the trials worldwide, be it the mRNA trials, be the adenovirus vector or the whole virion trials, number one. But we also know there is a lot of data that cancer patients have risk of COVID, cancer patients have risk of severe COVID, hospitalizations, ICU, and death. So that said, this is a very vulnerable group, and that's why most of the bodies like ESMO or ASCO or the Immunological Society, we're all endorsing that cancer patients be in the high priority list to get vaccination. Looking at the vaccine efficacy is not as good as the controls, but fair enough, anywhere between 70 to 90%, most cancer patients are producing antibodies. The question is, how long are the antibodies going to be sustained? How are going to be the T cell responses? But I think pretty much looking at our own data, which is unpublished yet, our data shows 85% are post first dose get antibodies and 95% post second dose have antibodies. So which is a very good number. And they are sustained over a period of time. This is unpublished data, but from our and from experts across the world with like the VOICE study, etc., from Israel, from Italy, and most other centers, cancer patients are producing good amount of antibodies, and that will hopefully hold them in good stead. Now, regarding the booster, those patients who had COVID earlier had produced more robust antibodies than those who didn't have COVID. So this is the basis that an additional booster would probably enhance their immunity. And India also has rolled out this booster program. And most of my patients, after their 2 doses, are getting their boosters on preliminary inquiry. So I think it would become a new normal that patients get their 2 vaccine shots and also their booster. My first advice or take home would be abstain from smoking, which is probably one of the most important habit forming exercises, which helps us to reduce the burden of lung cancer. That's number one. Number two is low dose CT scanning, which we didn't touch upon, which is popular, which has been shown to reduce mortality in the high risk groups, which is not that commonly used in India as a regular screening procedure. But again, if you ask me, rather than investing a lot of resources in a resource limited country, putting in a lot of money, getting regular scans done with a limited risk of radiation exposure, I would rather prevent our people from smoking rather than smoke and be in a high risk group and qualify for low dose CT screening. But for completion's sake, I think that is important. Three, excellent interventional radiology services are mandatory for a good pathology backup, for your histology and for a quick turnaround and for all your biomarker studies, which requires PCR or FISH or IHC by whatever platforms we do. Six, clinical intuition, more importantly. When a non-smoker woman or a man with an adenocarcinoma walks into my room who is supposedly sick and I don't have much time, initiating therapy early, or if he's unfit for chemotherapy, performance status 3 or so, empirical treatment as a last resort. These are some of the out-of-the-box things we have to think. Five, India is a land of tuberculosis. So never forget that you can have some nodules here and there on a CT scan, which could be old healed granulomas or tuberculosis, and we should keep that in mind when we interpret our scans. Finally, response evaluation and the fact that we're living during COVID times. Please vaccinate our cancer patients. 2 doses for sure. Booster, there is evidence, and if possible, go ahead with that too. With all this, I think, and good survivorship and good supportive care, the landscape of our cancer patients with lung cancer has improved tremendously. It's no longer a dreaded disease of the past where we used to give timelines of 6 months or 1 year. Most patients do very, very well, and the quality of life is excellent. That is what I think, as a medical oncologist, I would emphasize. And finally, in a country like India, the cost also is an extremely gratifying factor to treat, because most patients can be treated at a very, 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 very minimal cost with standard of care which is comparable to the Western world. Thank you.